You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, and this is Clinical Rounds, where we discuss topics of clinical relevance to clinicians. And today, I have a very special guest, Dr. Katie DeLuca. Katie, thanks for joining us today.
Thank you very much, Dr. Morgan.
So, could you tell us a little bit about yourself and your journey?
Yeah, so I'm a senior lecturer at Central Queensland University, which is located in Brisbane, Australia. I am a practicing chiropractor. I graduated from Macquarie University quite a few years ago. And around 2012, I pursued my PhD through the University of Newcastle, and that was around neuropathic pain in older women with arthritis. I had a short period as a postdoctoral research fellow, but now, I'm a practicing chiropractor in a small town called Southwest Rocks, and also a senior lecturer at Central Queensland.
So a senior lecturer and a practicing chiropractor. So you have a special interest, and that's geriatrics.
Yes, I do. We predominantly where I come from, we have a large proportion of older adults in the area. So I've heard it's similar to the Florida of the States. But yeah, I think during my PhD, I had a really good opportunity to specialise in older adults. And it sort of has been good for me to reflect on my research and apply that clinically.
Well, we were talking over lunch about how there's been a great interest in pediatrics, but if you're in practice long enough, your patients become geriatrics, and I must say I have a very increased interest in geriatrics at this point in my life. So what are some of the things that some bits of information you would share with our practitioners out there that is unique to treating this population of older adults?
Yeah, well, we have a globally ageing population, so we know that around 16% of chiropractic visits are older adults, and this is just going to increase over time. So most of my research has been around osteoarthritis and back pain, and a lot of the guidelines do sort of recommend exercise, reassurance, and spinal manipulation when indicated. So the biggest things to take away clinically is just to check for your contraindications to care. Osteoporosis, which is really common as well, the fragility of the bones. So you need to be careful with your manipulation, particularly of the thoracic spine. And also, we're going to be co-managing our older adults with GPs and family physicians, I believe they're called over here. So they're often going to be, polypharmacy and taking a lot of medication. So comorbid conditions or multimorbidities such as your hypertension, diabetes, our older adults will often have, a higher proportion with multiple medications. And so you really have to treat the patient and the complexities of our older adults quite carefully and take into consideration the whole patient. So
basically, as we accumulate more years, a lot more people are taking meds. They have diabetes. They have other conditions. The meds they're on are going to affect how you care for them.
Yeah, bone health.
So, but also you mentioned osteoporosis and degeneration. Your PhD was in
neuropathic pain.
Neuropathic pain. So, what can we do to help people with neuropathic pain?
Yeah, well, we sort of just come back to the guidelines. I think neuropathic pain is really difficult to diagnose and treat. So most of my work is around back pain now and osteoarthritis and prescribing with exercise and healthy lifestyles. We really recommend our older adults to lift weights. Resistance training is really important in that population. So we're doing more work on neuropathic pain, but I think chronic pain is it's a whole different...
So, foundationally, neuropathic pain is probably something better treated 25 years ago as opposed to treat it once it occurs. Can they prevent neuropathic pain? Are there things that lead to that? What are some of the things that we could change in our lifestyle to prevent neuropathic pain or neuropathy?
Yeah, I think your lifestyle choices along the way, food, diet, physical activity is very, very important. There's risks and a higher looking at occupational and how we sort of ergonomics during work. I think work is a really big it's very important these days, and how we work depending on whether they're going to develop neuropathic pain conditions with posture and function and things like that.
So dealing with posture, alcohol consumption, smoking, how does that affect neuropathic pain?
Yeah, there's definitely associations between the two.
Okay.
Yeah.
So, we're in the United States, we have a bill that's going through to expand the coverage for older people for chiropractic if it goes through, which means we may have an increase in patients able to see chiropractic. What are some of the things that, like, somebody walks in my office with stenosis? What special considerations would you give that patient?
Yeah, diagnosis is really important. So again, with our older adults, we do need to focus on functional ability. So we move away from pain and severity and intensity and look at their activities of daily living. So any kind of interventions which can improve function, walking capacity are very important in our lumbar spinal stenosis patients.
So a big part of what we want to do, I would imagine, would be somebody who comes to you has pain. So now they're not exercising, so now they're having sarcopenia, osteopenia. They're going down that spiral. It should be our goal through what we do to get them back exercising, to make sure if whatever we can do to help them remain mobile for as many years as they can. Is that ultimately your plan?
I think the greatest opportunity that chiropractic has is we provide care that enables them to be active and mobile and moving again. And so we have this opportunity to, manipulate the joints and prescribe them exercise, and that's where we have a really important role to increase mobility, range of motion, improve their ability to engage in activities of daily living, and then prescribe the exercise, get them moving again. So there is a continuum of care for the older adult.
There's also got to be a psychosocial aspect of this too, that you have somebody who's been active their whole life, and then every decade there's less and less things you can do. How do you help manage the psychosocial aspect of a senior?
Yeah, I think chiropractic plays a really important role. So if we're able to keep people healthy and mobile in the community, it impacts their psychosocial sort of values because they're able to engage in social activities. They might be out playing cards, going to their line dancing. They're able to go and buy their shopping and do things for themselves. So if you have an older person that's functionally well, they're actually able to contribute to society.
So making sure that they're active. It's our goal is to keep them moving, keep them active, keep them socially interacting. So you've got the unique place in life or positions where you're actually treating older people and teaching people and lecturing as well. Are you lecturing about geriatrics is what you're talking about?
Yes,
so what other things besides chiropractic do you offer in your practice? Nutritional advice? What other things do you do?
Yeah, we work very much integrate chiropractic with the services around us. Podiatry, I believe you have podiatry here in the States.
No, I've never heard of that.
So foot doctors also. So I work a lot with podiatrists. I think foot health and just making sure their feet work well is really important. Nutrition is really important. So a dietitian, obviously working with multi-morbid conditions, obesity and diabetes, working with a dietitian as well to make sure they have appropriate nutrition. Malnutrition, sarcopenia is also an effect of older adults that don't eat healthy foods or can't cook for themselves anymore. And you really need good relationships with your GPs. So often we're going to have older adults who have red flags to care, spinal stenosis, cognitive functioning. We as chiropractors will probably recognise cognitive decline sometimes more often than people that are close to them.
Oh,
so
really?
in your practice,
why is that? Because you're seeing it over
over
gaps
the years,
of time?
And we have the opportunity to screen. But if someone lives with them, they may not pick up that they're, a bit slower on answering questions, unable to fill out paperwork. Where if we see them for maintenance care, every couple of months, we might start to pick up that they're not talking well, their vision, isn't working, and pick up some of these neurodegenerative conditions. And that's where I believe we have a really important role.
So, from my practice, I remember one particular patient. He had osteophytic spurs inside his cervical canal, putting pressure on the cord. So he had myelopathy from cervical spondylotic myelopathy, which is relatively common, but it goes undiagnosed because it's not necessarily painful. It's because the cord doesn't register pain. So finding this, I'm like, oh my gosh, and this type of thing can even be made worse with simply range of motion exercises, let alone a osseous adjustment. Referred him to the medical doctors and they got myelopathy that's progressing, and but we can't operate because they've got heart disease, they have diabetes, they're morbidly overweight, all these different comorbid conditions that they couldn't get the surgery from. So it's pretty much live with it.
Yeah.
So
or back to you to manage it as best you can.
Exactly.
Yeah.
And for that case, and for cervical or myelopathy that takes place from degenerative joints or cervical stenosis, it's usually they're more clumsy, and then they have a wider gait, and they have bladder leakage, and all these things that they just, I'm just getting older.
Yep.
And it turns out it's not just you're getting older. You've got a neurological condition that you see those. It can be managed if they don't have the comorbids. They could be treated with surgery.
Yeah, and similar with the Parkinson's patients is that we have the ability to pick up tremors and the gait as well. And then once we manage with a neurologist to some extent, we also had a patient, we got them into the clinic, they were on the treadmill 10 to 15 minutes, 3 to 4 times a week in a supervised environment. And again, I think that's really key to managing some of these older patients. We did lots of manipulation of all the joints, we would do soft tissue work, we just got all those neurons firing, and he was very committed to the rehabilitation program. But he was 10 years we looked after him for who knows how many extra years of life, but we just worked with the MDs, we worked with the chiros, and it was such a rewarding situation because I think with the older adults, a little bit can go a really long way.
Oh, truly. And I remember when adjusting older adults before I became one, that with younger adults, I'm always trying to get that really I don't want to say rigorous adjustment, but you're trying to get that adjustment. And a lot of times you get just a tiny bit of motion with an older person, and they get a lot of relief. No audible, no big motion, but that's just getting a little motion in that joint gives them enough relief that they can go out and exercise it, and that they wouldn't have been able to do before. So what's the most rewarding patient encounter you've had with elderly adults?
Yeah, there's lots, and there's the big stories and the little stories, but it's a very simple case where I had a lady with just basically some knee osteoarthritis, and talking about this biopsychosocial model. I had treated her for many years and hadn't seen her for about 9 months, and when she came in, she'd put on weight and she'd had this sore knee, and I was talking to her and she hadn't been out of the house much because the knee hurt. And so, we do our mobilizations and our passive care, and then what I got her to do was to go get a stationary bike. I said, just get on your stationary bike. She had lost a lot of confidence in movement, and I was like, you can set it up, get moving, that's going to help the knee, lose some weight. And then I didn't see her again for a little while, and she sort of came back in, and I was like, how you going? And she goes, well, I'm outside, I'm in the garden. I said, okay then. So, providing more treatment, giving her some more exercises, and I saw her back again. How have you been? Like simple, buy a new pair of shoes. Then she started walking around the block. The knee pain reduced, she started to lose a bit of weight, and about 2 years later she had a haircut, and she came back and I said, you're a new person, and she said, I just needed the confidence to move again. Knee osteoarthritis, it was such a simple case, but I still think, it was just a lot of reassurance, it was simple advice, confidence building, and then obviously,
and managing expectations, and also the wins don't have to be huge wins.
They don't have to be, yeah.
And for somebody who can't garden, and they love gardening, if you give them that back, it's not like you adjust an athlete and they won the Olympics, but for that person it was the Olympics. Making sure you find out what they love. And establishing goals for them too. And also, there's certain things you can do, like for treating stenosis patients, finding that metric. I can only walk 2 minutes. And there's apps for your phone. You can actually have them monitor it. So you can measure it, and they can walk for 2 minutes. Okay, well, what's your goal? Well, I'd like to be able to walk to my neighbor's house, or I'd like to be able to go to the mall or go shopping and not have to sit down. And you put those metrics there, and as you're treating them, they can see the minutes increase. Now you've increased their quality of life significantly.
And I think that's the key with the older adults. What we do is improve quality of life. There's so many aspects other than just reducing pain that really matters to them. Similarly with that, if we live near the beaches in Australia, get to the beach and have your 2-minute walk along a nice path. So, where can you do your physical activity? And a lot of things are about either modifications or just maintaining what they have so they can continue to do the things they love.
Katie, thank you so much for joining us today. This is Clinical Rounds, and you've been listening to Dr. Katie DeLuca.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.